That's right. Good morning, Dr. Aurora. Am I saying your name correctly, or Aurora?
Yes, but please, Kavita.
Okay, awesome.
I
I'm
have
Mary
a
Louise.
terrible cold, so I will try to mute when I'm coughing.
Oh, I'm sorry. We have you talking a lot.
No, it was only 4 minutes. It was great. I could time it before and after. It was perfect.
And Mary Louise is going to help moderate / be our catalyst. So thank you. I am scribing for you, so I may not participate quite as much, although I'm happy to talk. But I'm going to try and take some notes as we go through.
Okay, I guess we can give it another minute or so for see, about
Yeah.
people joining.
Yeah, I know sometimes it's hard to figure out the joining part.
And I do have to leave after we're done with this. So, Kavita, if you'll do the summary for them afterwards when we go back to the bigger group.
Sure.
Thank you.
Actually, let me clarify. What time is that?
I think we stop at 1:05. Is that correct, Sheree?
Yeah, it'll be 1:05, and there'll be like a 5-minute warning at 1 o'clock that we should see also.
Okay.
So the summary is after that?
Yeah, there'll be a report out where I'm going to go around and just ask each room to spend a couple minutes sort of summarizing what they did.
Okay. I have a 1 o'clock meeting.
So everybody's has to be on that one.
Sorry.
All right. Well, I will do my best to summarize. How about that, since I'm taking notes anyway?
Thank you. We appreciate you. Thank you
Sorry.
so much.
No worries.
All right. I think maybe we can go ahead and get started. What do you guys think? All right, everyone, welcome. Thank you very much for joining us today with Dr. Aurora. We are going to go forward, and if anyone has any questions, please feel free to ask. And I'll just fill in where I need to. And I'm Mary Louise, the moderator for this group. So thank you for joining us today. Does anyone have any questions at this moment?
I joined this group with maybe an interest that's related, but not exactly about physician activism. But I'll introduce myself. I'm Alice Rushworth. I'm from the Tufts Clinical and Translational Science Institute, and we just our grant was just renewed, and hopefully we're waiting for our notice of award for starting in May. So we have a lot of new initiatives that we're thinking about. And one of them, in working with our community organizations, which we've had sort of some CVPR types of academic community partnerships for a number of years now, and spent a lot of time in the early years building capacity for research, and and then conducting small research projects with the community groups. And what we're hearing now from the community, especially since they've completed some of these research projects, is a need for building capacity and advocacy, that they have the research results, but they don't really know the path to affect change, and really the final steps of translation to change in policy. And we don't feel very equipped to do this either within the CTSI. Our investigators don't. This is not something we're necessarily trained on. So we've spent some time reaching out to various organizations and our partnerships. And, again, none of this has started yet, but I just was really interested in other people's thoughts about this and how we think about this in the framework of full translation, that we're doing this research, and often we're making some discoveries, and then we need policy change. And that we're not really, at least at Tufts, we're not so set up to do that. Even though we have a lot of policy researchers, they're not necessarily then equipped to take the next step to affect policy change. So I just wanted to throw that out to the group and see what other people are thinking about in that context.
Did you want to start, Kavita, or?
Yeah, sure. So It's interesting that you say that because I actually generally introduce myself as a translational research with the caveat that it is not bench to bedside, but rather bedside to policy is how I describe my translational research. And so I loved that continuum that you described of how to take your research and turn it, from the academic spaces and move it out to the community spaces. I think a lot of it depends on who owns that policy, right? Whether it's at the local level, community level, state level, national level. I can think of, projects that I've done with the Cleveland CTSC's support and gathered local data and then presented to, my chair, the board of directors for the hospital, the formulary committee, those sorts of folks. So I think it's identifying who's in charge, like who have the levers that you need to be pulled, and then who your stakeholders are, who are your partners in this. And I think in all of that, it's really important to think of patients as partners in the process as well. For the other end of the spectrum, from the local community level all the way to the national level, another example is my work mainly centers around the Medicaid sterilization policy. And so for that, for years, I've been responding to, and as part of organized medicine efforts too, through national organization, have been responding to open calls for HHS for revision of the policy. And we always present a very sort of data-oriented response. And you know what? Hasn't gone anywhere for about 20 years. And the reason is we can only speak from the academic lens. So it wasn't until recently where this message, I feel like, really hit home for me, that I realized that I need to actually partner with patients and patient groups in order to better understand what their perception of it is, what their impact of that policy on their lives is, study the things that matter to them, and form a coalition that I feel like we've actually made traction at the national level in a federal health policy change. But the ratio of folks in our meetings is very different than what you would typically conceive in academia. So we just had a meeting to advise HHS on this. There were 15 representatives from patient groups and one person from academics. And I think that was really important to really send home the message. And that was super intentional, that the power belongs with the patients and the patient groups. And our job is to help get data to fill in the gaps of what their needs and preferences are and where those questions are, so that we can advocate together.
And are you aware of any kinds of trainings or that kind of building capacity for community organizations? Because my perception is they're very interested in doing this with CTSI, but they're very interested in doing this period with their own agenda, some of which we're involved with, some of which we're not. So just generally, are you aware of programs or curricula that we could begin to look at to see and tailor for our purposes?
I think as community-based participatory research gets stronger and stronger, right, whether it's recognized through PCORI or other mechanisms, I think it's gotten a foothold in forming those infrastructures. But I guess I would say two things: that it's okay if they have their agenda. They're supposed to have their agenda actually 50% of the time in a partnership, right? Academics is only supposed to drive that agenda half the time if it's a true partnership. And ideally, we would collaborate and come at an agenda that both feel comfortable about together. And the second is, I think community-based participatory research is one thing, and then translating it to community-based and led advocacy is quite another. And they are way ahead of us in academics in that space, right? There are so many grassroots patient advocacy groups that are well run, that are have resources, and more importantly, have gravitas and a voice and authenticity. And I think that's really important to partner with them to support their missions with our data, rather than coming to them with data and saying, sort of, can I use your network to leverage me?
Yeah. I don't think, any of those are issues, but that, I think you made an interesting comment, because we're working with non-patient community organizations, And so they aren't as advanced as the patient community organizations in this advocacy piece. So that's a good suggestion to really look to the patient advocacy models for what's effective in designing curricula for community organizations that aren't primarily patient, they're more community oriented. Thanks, that's helpful.
And I don't mind adding in that sometimes you have to look in the various departments that you wouldn't think to look at, like from the hospitals. Like we have a biomedical department, which is phenomenal as far as like even now they're in the inner city trying to advance like mental health and engage, with the local partners like the churches and like the local community health facilities like in the Glenville area. So even though, they're doing something I wouldn't have thought. I thought that would have been something from my department in psych at the Cleveland Clinic, but it's the bio, ethics department that's out here in the community. And they actually have like feet on the ground and they're with the grassroots organizations and they're representing the people, the real people, and not just the ones in the boardrooms or, in the office. So yeah. Oh, Miss Jacqueline.
Yeah, hi. I'm so sorry. I had to jump off and then I'm jumping back in and just been one of them kind of crazy days. But I'm Jacqueline Hayes. I actually work for Anthem Elevance Health. I don't know if you all are familiar with them. So we have a new branding name, Elevance Health, which has all the auspices of our different insurances there. So like Anthem, AmeriGroup, Healthy Blue in Louisiana. So the reason, of course, this is such a wonderful topic right here. And what you were saying, Miss Mary Louise, is so apropos because that's one of the reasons why I jumped off and now I'm jumping back on because the team that my associates, so I have 5 states that I work with. And so for the states, we are concentrating and being very intentional about what my team does. And so primarily we are there are health promotion consultants. And we concentrate prior on more of the clinical side for our members. And what I mean by that is, we looked at, them getting access to a doctor, concentrating on high blood pressure, diabetes, mammograms, things of that sort. But now there's been a shift in our work. And so what my team is focusing on now is going back into the community and being very intentional around food disparity, around mental health, and around access to care. So I just had a conversation with my team because prior to during the pandemic, we came up with a huge resource list out of these 5 states. And at the time we had a lot more staff and we thought of every area that would impact our members. And so this resource list is now being tweaked to concentrate on those particular areas that I just mentioned. But now we're asking to be a part of all organizations and really being innovative around who is doing, like what you said, Mary Louise, you wouldn't think that would be doing that type of work, but we're asking to have a seat at that table now. And so, what does that really look like? And I think, like I told them, so you can't look at the traditional member. We're focusing on the dual eligible member, but you can't look at the traditional member anymore. You have to really look at a lot of the other areas of care. So as I was saying yesterday at a program, in what I've done, because I came from Cleveland Clinic, so I was there for many years, Mary Louise, and I stepped into now the insurance world. But and I was lured by this position of what I do. But so much of what I did when I was at the clinic, and I was in East Cleveland, Mary Louise, so I saw the brunt of everything. But what I know is that social determinants, those barriers, is what drives members to their care. So if they don't have the social barriers together, they could care less about their health. That is on the back burner. And that's so much of what I saw when I worked in East Cleveland and worked at the hospital. So I think that as we, continue to do the work in these communities, that we have to look at a lot of untraditional type of care and a lot of untraditional type of partnerships and collaborations, because that's really where the substance of where a lot of these people exist. So I'll say that, and that was my 2 cents. Thank you.
Thank you, ladies. I think you guys are all giving phenomenal ideas. I'm taking notes too. Does anyone else have any more comments or questions? Okay.
I can
Mm.
just comment on the it's interesting, Jacqueline, what you were saying a little bit, and it also tied a little bit, Alice, to what you were saying, which is, we're doing a lot of projects funded by Ohio Department of Medicaid. And so we've been able to make a lot of policy changes through the joint activities of that project. And so it's quality improvement science or implementation science. So it's already sort of translational science, but we're doing it funded by the payers, but also in partnership with the Medicaid managed care plans, as well as patients and clinics. And so I think it raises up sort of the barriers and challenges that are happening around specific conditions and allows Medicaid to sort of respond to that. So I think that's been one way we've done that. Obviously, that doesn't work for every single research project, but thinking about ways to incorporate the person who's changing the policy in the actual research you're doing then allows them to see that in a very real way. So that's just a general comment, but just doesn't always work for every research project.
So I have a question that was provided by someone earlier. So what do you think are the greatest challenges for providers who want to be activists in 2023? What are some of the barriers they have to overcome to truly engage and make change or make improvements for their patients? There you go.
I can start, but I also want to give space to if anyone else wants to. I honestly think one of the biggest barriers is time and related burnout, right? So in healthcare in America is a business and it's run like a business. And so as long as profits and the bottom line are centered, we will always continue to prioritize treatment over prevention, quantity over quality, and downstream over upstream. And I think, to me, this is where is a fundamental question of what is the goal of medicine and what is the goal of health and healthcare are sort of different, right? Because the goals of medicine and the goals of healthcare in America today are not perfectly aligned. And I think if we have ability to carve out space for leaders, and I don't mean just physician leaders, I mean healthcare leaders, to actually capitalize on what their jobs are, which are to promote health and healthcare, but do it outside of the traditional healthcare spaces and do it through community partnerships, do it through community education, do through advocacy, that we would actually improve health in a much more cost-effective, proactive, and meaningful way.
Yeah, Kavita, I think that's right. That time is a huge piece of this, that especially even, whether you're a physician activist or you're doing research, a translational research project, and you want to advocate, a lot of times you're spending time writing the next grant and looking at the next thing you're going to answer. And so it's finding that time to do that work, which can be challenging. And then I would say the second piece that Alice, you sort of brought up is like, well, we don't even know who to go to influence policy or who does it. So sometimes the navigation of the system is really challenging. And as you mentioned, Kavita, the frustration, I spent 3 years volunteering my time on the National Clinical Care Commission about giving Congress recommendations on federal gaps in programs and policies. And that's 3 years of volunteer time that I will never get back. And, then you're like going, okay, then we're trying to spread that, and Congress was supposed to act on it, but like they don't have to apparently. So it's a lot of time we spend sort of pushing an agenda that may or may not lead to change, right? So I think it's time, training of like who's going to do it, and then it's also dealing with some of the frustration of that, which can be challenging.
Yeah, I think systems and structures produce the results that systems and structures were designed to produce, not different ones, right? And so we right now have not merged our systems of research and policy. And so, for example, right, I wrote a grant to the NIH, and my program officer was like, AIM-3 is too policy oriented. That won't work for the NIH. You're going to have to submit an AHRQ grant, right? It doesn't make any sense. If the entire project is about changing a Medicaid policy, why would I gather the information in one part and act in the other, right? Like, why can't I move from stage 2 to stage 3 in that Kilbourne framework simultaneously? Like, that was the whole point. And so I think at some point we just have to think critically about whether the structures that were designed, 50 plus years ago are working for the goals that we have now.
I think you guys brought up some excellent points, and even earlier in the part of the program, someone talked about voting, getting people out and building capacity, like in the communities. We have to educate people, hey, voting does matter, because our politicians, that's ultimately the people who really make change. They're the ones that can make hospitals change policy. So that means we have to, unfortunately, there's a lot of myths out there, and people believe their vote doesn't matter. And I don't understand why, because we have seen over the past, several years, that people have done everything they can to stop voting. So we need to, I think that's something that, that could be a part of what we do also as professionals out here. As we said, we want to engage people. I think, unfortunately, there's a lot of education we still need to do in removing emotions and look at it with a different perspective, so they can understand how important they are as individuals, and they matter. And I think a lot of people that we say we want to help, especially, within this, they don't realize that they matter. And because of that, they don't have a voice, they think, and they don't make a noise. And we're trying to do it for them, which is really not the right way. And that's what we're talking about, right? Trying to bring the people back into this. So that's kind of something we need to work on also, not just at the top, but also at the grassroots level, in the community level. I guess you kind of alluded to something already. It's another question I was given. But you already kind of alluded to it. Should research inform policy, or should policy inform research? Anyone can respond. Even you, Miss Alice, over there.
I think it's both, right? I mean, you want to do research on policy, and then you want your research to affect policy. So I would say absolutely you want both. One of the things that we're doing or thinking about a lot, and it's I was torn as to whether to go to the social determinants of health data group, is we're working a lot in that space, but also trying to make sure that policy data is aligned with that social determinants of health data in a common data model, so that those kinds of research can be done in different sectors. And that's at scale, at broad scale.
Alice, can you say more about that? Like, do you envision, like, okay, these data would be really important for policy, and so we want to collect that, or are you thinking of it in a different way?
Well, I'm hardly the expert on this, but I can just say in a very recent line of research that we're thinking about is looking at gun policies, and then understanding gun violence and homicide, suicide, all in all of its parameters. And so getting trying to triangulate all that data so that you've got the lethal and non-lethal injury data with all the metadata associated with it to understand what's really behind it, and then the policy data, and trying to do that. You've got a great natural experiment in the United States with very, very different policies in different parts of the country. And so being able to bring all that data together in a common data model is a very big lift, but just one of many, many examples that you could think about. And we're doing this mostly through, and this is now starting to get very technical, particularly for those people who aren't part of the CTSI world, but the common data model, the Odyssey common data model, the OMOP common data model. Of course, we've got I2B2 that we're all working with, but that Odyssey open source community has all these working groups in these areas that are trying to do this at an international level, and how to bring the data from all these different sources together under a common data model so they can be used for that kind of aligned research.
In fact, I saw Valerie's chat earlier. I don't know if she wanted to unmute, and I know that it wasn't related to what Alice just said, but I didn't know if you wanted to talk a little bit about that.
Sure. The information that I put in there was in regards to, I was actually the health manager at WellCare, and I've often thought that healthcare entities need to be at the table as well. There is plenty of excellent data that they collect on patients or clients who come in. And so I thought I was just piggybacking on Jackie's information, and I think that is very interesting to now have them come full circle and come back to the table, because I've often thought that that was something that was missing. I also think that it's both as well when you're talking about research and looking at implementing policy. I think it's a dual thing. And I also think that the community needs to do more community participatory types of trials in the community, because that builds the trust in the community as well. So those were my only comments. Very good dialogue and very good information as well.
Yeah, so that's kind of how it all happened. But it's always like,
thank you. I appreciate that. And does anyone, I think we're all going back to the same thing, right? We said we will need to bring the community involved, get them involved a lot more, because this is who it's about, right? This is what we're spending all this money, time, and effort and energy for. So does anyone have any ideas how we can go about doing that? So that's what we have caused changed already, right? George Floyd and a lot of things occurred, and now healthcare disparities and DEI is like the word out there now, right? It's like the buzzword. So how do we keep this momentum going so it doesn't die down like it has unfortunately past? It's risen and then it falls back. So how do we keep this going so we can truly make change this time going forward?
Yeah, I mean, personally, we've spent a lot of time thinking about this at Tufts. I frankly think in terms of research, it's going to take that kind of advocacy at NIH to get policy change there. We're very committed to compensating community, engaging community participants, understand that fully, have been evangelizing about that a lot. But if the study budgets don't have that and require that, then it's going to be, it's sort of a heavy lift. So I think we are trying to think about bringing organizations together. And it's a little frustrating because NIH, at least with the CTSIs, are very clear that this is priority work, but then it's not really supported in the funding opportunity announcement. So there's a disconnect there, and I think they have to own that and change that, and that will be a huge motivator, as well as then beginning to think about journals also are a good lever. If journals are requiring the stakeholders to be involved and have specifications around that will really motivate change for investigators as well. But that kind of change is tough.
Yeah, that's great. I think that a lot of people see like PCORI as, okay, well, that's the group where you have to have patients and community,
Right.
and the other agencies are not as active in that. Valerie, were you just about to say something? I didn't mean to cut you off.
Oh, no problem. And I was actually looking at some information from the CDC, and it was in regards to community engagement. And it was actually a course that you could take on community engagement. And I think that that's one of the strongest components as well. You have a lot of people that are very interested in research, but they may not know how to engage the community. And that's very, very important. Prior to this position, I was in community outreach, and we actually were in the communities, and we talked about different types of cancers. But I think that there's a way that you work with the community, and there's a way that you can be successful in getting information, but they have to trust you, and they have to believe that you're going to do what you say you're going to do, disseminate the information, treat them as professionals should treat their patients, their clients. A lot of times people would say, oh, you work in the community. And I thought that was interesting, because when I was a patient advocate, I actually worked with the patients, and, oh, you work in the community. And I'm thinking the patients that are in the community, they are patients. Very much. They are patients. I would have different people that would come up to me and say, do you know Dr. such and such? Do you work with Dr. this, or etc.? And so I think we have to merge the two and understand that they are one. And I think once we begin to do that, we'll have true community engagement, not the separate, you're here and I'm there. We're all in this together. And so I think that's a very important component of working with the community, that we are one instead of separate entities.
Have you look at it? She's like, she just wants to get the point across. Patients clinically stable.
I think
that
to
she came out
me,
next
probably
week.
the most sustained way to ensure that equity remains top of mind in sort of a long-standing fashion is to think who is on your teams. If research teams continue to look like what they currently do, they will study things like DEI and equity because, as Mary Louise said, because it's the thing to do at the moment, without the lived experience and community backing and historical background to really live up to why we are doing this. And so I think the more that our study teams look like the people we are trying to help, the more organic the subject matter at hand will be, and the more easy it is to sustain an interest in it, because it's no longer artificial, it's personal.
Anyone else have any comments? Ms. Jacqueline, how's you say your team is like now more so out in the community, at the grassroots level, and how are you like doing that successfully? What is that looking like? What approaches have you maybe like, oh, that didn't quite work, so now we've had to do this instead? Or, what are you utilizing that's effective?
Well, what we've done, see, like I said, during the pandemic, we came up with a massive resource list for all 5 of the states that we work out of. And it was inclusive of everything at that time, from banking to food banks to, mental health organizations and everything. So what they're doing now is we filter the list down to really address those 3 areas that our leadership has asked, which is the food, insecurity, mental health, and access to care. And so now they're thinking out of the box as far as doing their research now with these different entities. And so it's very inclusive of any and everyone, really, from governmental relations to, nonprofits that you may not even think about working with. But us as asking to be a part of their organization in whatever capacity that is. So if they like with the food bank, if we are able to volunteer on a consistent basis so that, you know, as individuals come to support and receive the food, that they can have a conversation with us from the insurance. And that may, you know, spark up a different type of, you know, conversation about the health, where they are, or questions, you know, it could go anywhere. So just us being able to have a seat at anyone's table, really, you know, so much of my work, and I know Val and Vincent very well on this call, hey Val, has been rooted in the community. And it has been really working with kind of that, the harder population, which is what we're targeting, the Medicare, Medicaid population, because they're very transient and they move around a lot. And as I say, they don't necessarily have all the parts and pieces in place. Housing, you know, they may not have a phone. You know, and the health becomes the last of their interest, and that becomes an interest if they don't feel well. So the reason why we're looking at access to care, because there's a very big need now with just getting doctors. A lot of doctors and healthcare providers retired, closed practices. A lot of that happened during the pandemic. So now you have a very streamlined workforce, and it takes years to be seasoned in many of these fields, especially with mental health. That's not something that, you know, and you come out of school and you have all the tools, but it takes some seasoning to it to really to address the real needs. And even as physicians, you know, so much of what the residents that would come through, and I started at Huron, was them really having conversations with us to talk about the different type of patients that they will be encountering, and understanding the cultural barriers, understanding some of the environmental barriers and things like that. So those are, so this is what what we've been doing for some time now, is making phone calls and working with various populations. But I will say that from when I did it, the need was the same across the various states. So I don't think that there's as much of a difference as maybe some people may think. I think that the need for housing was huge. The need for therapists was huge. All of that was pretty much the same across the board. But it's just like I said, if you don't know how to get to those entities, it becomes very challenging, and people get frustrated, and they give up. And so I'm a very reactionary type of person. So, you know, when I was at the clinic, I was always very making sure that I would try and get them into a doctor within a certain amount of time, because I know that if they walked out that door, I might not see them again, you know. And then I'm also the type of person that when, and even with my team now, you know, I believe in having very tangible things there for them. So when they go to meet with the different organizations and agencies and stuff, you know, they will have good information to share, to show the brand and who we are and what we represent, and how we can make an impact with this vulnerable population of people. So that's kind of what we're doing, Mary Louise. It's going to be a learning curve for some, and then for others, but everyone on my team is just very excited, because we've not been able to get back in the community because of the whole pandemic. And so everybody is, you know, we still doing virtual like we're doing here, and people are gradually coming back into the fold of doing in person, but it's still a lot of virtual that's still happening. And even though the COVID it's talked about, but not as talked about, you know, it's still in people's minds, and it's still in the minds of many of our members, because you have to understand they have these comorbidities that they live with every day, and they are scared to a certain degree. Even if they catch a cold, they feel like, do I have COVID now? You know what I'm saying? So these are the things that they still deal with, and that we hear about. So at least if we're there on our side, you know, we can be a visible presence to say who and what we are and how we can support and direct and be aligned with and help them. And that's the beauty about one of the reasons why Elevance Health decided to come up with this name of elevating one's health, because we know we did insurance well, But now we have to look at, there's more to the insurance than just insurance. We have to look at the whole health of a member. And that's what we're doing now. So that's what we're addressing now.
Thank you. Did you have something to say, Valerie? I see you.
Yeah, most certainly. Great to hear you, Jackie. How are you? Say, wait a minute, is that Jackie? Nevertheless, the other comment that I have too is in regards to NIH making sure that they have a component of evaluation on each and every one of their grants that they fund. You have to go back and see what the outcome is, what happened with that particular grant. And I know from working with on the federal end, I used to work at an agency called the Area Agency on Aging, and we had a component of evaluation. So we always made sure that we went back and we wanted to see the metrics. If we funded you, we wanted to see exactly what you did with those particular dollars from the top to the bottom. And I think that that's something also that NIH should do. Perhaps it's something that they do, but I think that they should also share it with the community. What was the outcome of that particular grant? What type of metrics were used? Look at it from that perspective. And then I also think that you have to define what community is, because after COVID, as a social worker, I've seen a lot of problems that have arose from that. And we're going to have to address that before we move forward. And so I think that that's also something that we're going to have to do before we can get into the research component. We have to address what is community, what does it mean, and what should we be focusing on? Is the focus still the same? So I think that's very important as well.
And I think you guys have mentioned already, like meeting people where they are. I mean, it's been alluded
Yes.
to. And one thing
Yes.
I am proud to say I didn't work at Huron Road, but I'm at Stephanie Toast Jones, which is, the remnants of it, right? And actually, I'm working on a grant with the bioethics department to actually provide education at churches in the community. We're talking about working at the Glenville community. There's a church, we've already talked to the pastor there and the council person for that neighborhood. And we're talking about also reaching out maybe at the Salvation Army, because they have a in East Cleveland, because they have a captured audience. These people do utilize these institutions. So it's like, why stress out trying to reach people when they're there? And people talk, right? Especially in these like old school inner city communities, they talk. So word gets out there. So it's like reaching out and say, hey, let's do some education. Let's hear you. What do you want? What do you need? And as they hopefully get comfortable with us, because we're in their environment, then they're like, you know what? I'm willing to come see a therapist or a psychiatrist or whatever. And we can make the appointment right there and then. So that way we're not walking away and say, here, call us. Because you're right, when you walk away, that's done. So sometimes we have to do these extra steps and extra work to make it happen. And one of the things, I don't know how it's going on in other states around the country, but in Ohio, we're going to lose a lot of Medicaid participants. So I'm curious how, we only have a couple minutes left, but I think it's worthy to talk about how is that going to impact our advocacy, or even are these people just going to be lost to the healthcare system? Because insurance, HCAP included, which is what the Cleveland Clinic has, is not affordable for everyone. It's a lot of single working moms out here. There's a lot of single working dads, even people who are dads just struggling. So I'm sure that's going to impact us and all of us in every part that we do, insurance, social work, research, everything. Any last comments, Kavita, before we leave? You'd like to leave us any pearls? I know you have a pearl or two to pull out.
No, I've really enjoyed the conversation and learned a lot. So thank you all so much for sharing your expertise.
No, I learned a lot. Like my notebook is full, and I have a student next to me. She's been taking notes and like really into everything also. So, and she's like excited, and I'm building off of her excitement also. So I thank you guys. I thank you for the information and the education, and I'm hoping to maybe reach out to you sometime in the future.
Yeah, thank you.
Thank you.
Thank you. Wonderful conversation.
And thank you, Sherry, for taking the information and sharing this.
Yes, I will
with us.
share out and do my best. But for those who are able to stay for the report out, they can add if I miss anything.
All right. Thank
So,
you so much. Everyone have
all
a
right.
phenomenal, phenomenal day.
You too.
Thank you.
Thanks.
Bye.